Plasmodium species have different incubation periods and life cycle durations, helping with the diagnosis to some extent. P. falciparum has a very short incubation period, making it the most likely species if a traveler presents with malaria just a few days after spending a short amount of time in an endemic area. If a patient presents with symptoms after a month spent in an endemic area, other malaria parasites can be considered. The cycle time represents the time needed for parasites to grow inside the red blood cell and rupture it. The main clinical symptom of malaria, fever, is caused by this rupture of red blood cells. Thus, if the cycle time is 48 hours, the fever occurs every 48 hours or every third day. This is called tertian malaria and would be seen with P. falciparum, P. vivax, and P. ovale infection. In P. malariae infection, fever is seen every 72 hours or every fourth day and is called quartan malaria. If a patient presents with malaria a year after returning from an endemic country, the list of suspects is narrowed by half to P. vivax and P. ovale, as these are the two species with latent stages in the liver. The clinical manifestations of malaria are described as the classic triad of paroxysmal attack, anemia, and splenomegaly. In the course of infection, there is usually a prodromal period when fever is not regular, but after a few days, the fever pattern becomes tertian or quartan, depending on the Plasmodium type. Paroxysmal attack is seen when merozoites rupture the red cell membrane and enter the bloodstream en masse. During the, quote, cold stage, the patient has severe chills while the temperature is rising, lasting about an hour. During the, quote, hot stage, which lasts 4 to 6 hours, the temperature rises to 39 to 41 degrees Celsius. As this fever decreases, the patient experiences drenching sweats. This, quote, sweating stage lasts 1 to 2 hours. Other parts of the triad are also closely tied with the pathogenesis of disease. Massive hemolysis is caused by the parasitic rupture of red cells, as well as autoimmune mechanisms whereby immune cells recognize infected red cells as foreign. This process results in anemia, and, with a large number of lysed cells, the liver cannot bind all of the freed bilirubin, and hemolytic jaundice occurs. The removal of ruptured erythrocytes, as well as constant antigenic stimulation, together cause splenomegaly. All of these complications are seen predominantly with falciparum malaria, which causes the most severe disease. The pathogenesis of most complications is massive capillary damage and vasculitis caused by parasite reproduction with destruction of red cells. Cerebral malaria accounts for more than 80% of deaths from malaria. The clinical presentation includes increasing headache, restlessness, and generalized convulsions, followed by increasing drowsiness, progressing to stupor and coma. The pathogenesis of this condition is reproduction of the parasites in the brain microvessels, causing obstruction, vessel ruptures, and hemorrhages. Acute renal failure, caused by reproduction of the parasites in renal glomeruli vessels, presents as oliguria and uremia, progressing to complete anuria with rapidly rising blood ammonia products and potassium, which can cause cardiac arrest. Acute respiratory distress syndrome, or ARDS, presenting as pulmonary edema, rises in association with severe acidosis and renal failure. Algid malaria, algos means cold in Latin, is an acute shock syndrome with vascular collapse. The symptoms are typical for shock of any etiology, including severe hypotension, rapid faint or impalpable pulses, and oliguria, which may lead to anuria. Disseminated intravascular coagulation, or DIC, is caused by massive intravascular damage. The host responds to the damage by hypercoagulation to stop the hemorrhage. But as the host runs out of coagulation factors and proteins, a prolonged hypocoagulation stage begins, with the constant danger of life-threatening hemorrhages. In blackwater fever, or malarial hemoglobinuria, the urine turns black as the released hemoglobin in serum begins to appear in urine. Sometimes treatment of malaria with quinine or other oxidant drugs, such as primaquine, may be responsible, although the causal connection between drug and disorder has never been proven. This condition is more common in patients with G6PD or other red cell enzyme deficiencies and is associated with acute renal failure. Plasmodium falciparum causes the most malaria fatalities by far. This Plasmodium species reproduces predominantly in the microcirculatory bloodstream, where infested red cells are sequestrated, potentially obstructing small vessels in the brain, kidneys, and lungs, causing severe complications including cerebral malaria and acute kidney injury. P. falciparum may invade erythrocytes of all ages. Its reproduction is very rapid, and one host can simultaneously have more than one generation of plasmodia, leading to very high levels of parasitemia and alterations in the classic fever pattern. Plasmodium falciparum trophozoites look like delicate rings, occupying 1/4 to 1/6 of the cell diameter, commonly with 2 nuclei. Each red cell usually has more than one trophozoite. Host cells are not enlarged. Falciparum schizonts are smaller than the schizonts seen in other types of malaria and contain 8 to 24 merozoites or new parasites. Macrogametocytes are banana-shaped and usually occur a week after onset. Male gametocytes are crescentic in shape. A section of white matter of the brain from a patient with cerebral malaria is seen. It shows capillaries engorged with parasitized red blood cells. On the left side of the picture, one vessel has ruptured with surrounding hemorrhage. P. vivax preferentially attacks young red cells or reticulocytes, so only a small percentage of red cells is affected. That is why P. vivax malaria usually has a more benign course. During the natural course of infection, P. vivax attacks usually last 4 to 5 months. Due to hypnozoites in the liver, the disease can be seen after long incubation of 6 to 13 months, and late relapses can occur even after 3 to 4 years, though most relapses occur within 1 year. This slide shows blood smears representing different stages of P. vivax. On the upper left, we see young trophozoites, or ring stage, seen most commonly during an acute infection. The rings appear thick, occupying 1/3 or 1/2 of the cell diameter. The host red cell is enlarged and stippled by fine, round, uniformly red or red-yellow staining dots, also called Schaffner's dots. On the upper right, we see a schizont, a dividing stage with 12 to 24 new parasites inside. The lower picture shows a gametocyte, or sexual cell, which is round. This is a female gametocyte, which is slightly larger than male gametocytes. Plasmodium ovale malaria is also a relatively benign disease, similar to P. vivax. This Plasmodium species also prefers reticulocytes, so only about 2% of red cells are affected. It is also tertian type and can have late relapses due to dormant stages in the liver. Duration of the natural course of disease is about 2 years, though late relapses can occur in 3 to 4 years. It is highly endemic to Western Africa. Plasmodium ovale trophozoites appear as thick, compact rings, occupying 1/3 to 1/2 the diameter of the red cell. Host red cells are enlarged, elongated, and oval-shaped, giving the name to this type of parasite. They have numerous Schaffner's dots, but are paler than those seen in P. vivax. The schizont form has 6 to 12 merozoites that are arranged irregularly like a bunch of grapes. Gametocytes are round or ovoid by shape. Plasmodium malariae is generally considered the most benign type of malaria. This Plasmodium species affects only aging red cells, causing very low levels of parasitemia associated with mild clinical symptoms. The cycle time for P. malariae is 72 hours, with attacks every 4th day. The P. malariae trophozoites appear as small, thick, compact rings, occupying at least 1/3 of the cell diameter. A small chromatin dot is seen. The host red cells are not enlarged. Merozoites in a schizont are arranged symmetrically, often in a rosette or daisy head formation. Each schizont has 6 to 12 merozoites. P. malariae gametocytes are round or ovoid by shape. Plasmodium knowlesi is a zoonosis and is now recognized as the 5th commonly occurring form of human malaria. It is endemic in Southeast Asia, including some areas previously declared malaria-free or at low risk of malaria. The epidemiology of this disease is very different from other forms of malaria. Plasmodium knowlesi malaria has a monkey reservoir, and disease is transmitted to humans by mosquitoes that normally feed on animals. People become accidentally infected when they enter the ranges of the vector mosquitoes and animal hosts. P. knowlesi is the most recently discovered human malaria parasite. It accounts for up to 70% of malaria cases in certain areas of Southeast Asia. It has a short erythrocytic cycle of 24 hours, indicating rapid reproduction, and can cause severe disease with high levels of parasitemia. As it is found in areas that are reportedly free of the other 4 types of human malaria, such as Thailand and Singapore, healthcare providers should be on alert. The morphology of P. knowlesi is similar to P. malariae. As for treatment, P. knowlesi responds well to chloroquine, mefloquine, and primaquine, and these same drugs can be used for chemoprophylaxis.